Welcome back to Fertility Edge. I'm your host, Alice Creasy, creator of the Fertility Answers mobile platform, where trusted experts answer your personal questions. Today's show is the Infertility Workup. It's a guide for straight couples with two very special guests, and perhaps the first and only mother-son IVF team from Southwest Fertility Center in Phoenix, Arizona. I have with me the matriarch of the practice and of the family, Dr. Sujatha Ganala, and also her son, Dr. Vinay Ganala. Thank you both so much for joining today.
Hi, guys.
Am I right? Is this the only mother-son team in the U.S.?
I know there are father-son teams, but I'm not sure. As for the mother and son, I'm not 100%. But
well, that is part of the incredible story that you have, though, is that you were one of the first fertility practices that established itself in Arizona. So you were very cutting edge as a woman, right? As a female IVF doctor.
I mean, I was one of the first pioneers, actually. As you know, the world's first test tube baby was born in 1978. That's when I started my fellowship and opened the practice in 1980.
That's amazing.
So the first IVF baby in US was born in 1981. So I just was setting up a practice at that time and then started a gift procedure back in 87, 89, and then our first IVF was back in 1989.
It's incredible. I mean, what a visionary. You know, all those years ago when fellowship, it wasn't even a very big fellowship back then. How many people did you graduate with?
In our program, there were 2.
That's it? 2?
That's it. 2
oh,
out of 2. Yeah.
Oh my gosh, that's incredible. Well, I'm really excited to talk about this topic today because no matter what a couple's collective age is, if they're having trouble to conceive and we know that they need an infertility evaluation, so many couples don't get in to get one. So I think what we want to understand is when someone is nervous, when a couple is nervous, what are the things that they can expect they're going to learn about and embark on at that very first consult with you?
It takes a lot of thinking, emotions, before even a woman or a couple commit saying that they have a problem. Before they admit that there is an issue, they're so afraid to even talk about it or make an appointment. Just from my experience, they make an appointment, but they also no-shows. No-show rate is very high in infertility practices. That's because they're not emotionally ready. They're at a stage that why me syndrome, you know. But when they do come to us, at the it takes a lot of effort, emotional. They have strength and they have to have a confidence and strength in themselves to even admit that there is a problem. So when they feel like there is a problem, because they cannot, this is a topic they cannot talk to their next door friend who has
right.
2 children, right? So they come to us at the initial visit. What do we do? When the couple come to me sitting across my table, all our life, what do? We prevent pregnancy from the time of puberty. And all of a sudden they wake up. Everything is set now. They want to have this baby tomorrow. And when I explain to them how inefficient system is reproduction, I'm sure you will address later in a different session, they are so shocked.
I completely agree with you. That is probably one of the most common things that we hear over and over is like, I spent my entire life preventing pregnancy and it turns out I didn't even need to, right? I took all the birth control and then women start getting into their head about it and they wonder, did my birth control cause it? We hear that all the time, you know? I mean, we went through a phase at the end of last year. It seemed like every other registered user was asking if her Depo shot caused infertility because women were it was already past 6 months and they still hadn't gotten their period back, after getting their last injection.
Right.
And so we hear that all the time from women is like, oh, did the birth control cause it? Did, this, that. And so the more that we can advocate, don't look at the past. It's, but yes, that we can wake them up to proactive planning. Let's say it.
Okay,
Proactive
wonderful.
planning.
Yes.
Yeah.
First visit is very important. That's where we are really assessing the whole history of both. If they are married couple or they are in a relationship, she's coming with a partner. We are taking the male and female history on them. In the history, it is very comprehensive history. Infertility initial visit takes about 1 to 1.5 hours.
Wow.
For us to evaluate. So in that, we start with number one, obviously the age, height, weight, and if they have had previous successful pregnancies, miscarriages, and then the age they started, complete gynecologic history, which addresses the when they first started their menstrual period, the age of puberty, menstrual cycle history, the associated symptoms, which we are addressing by asking the questions, we are assessing if there is going to be any underlying physical problems for that woman. So one is gynecologic history. In medical history, making sure there are no contraindications for pregnancy. Not only that, how to approach their treatment. Past surgical history is very important. And then their personal history, their habits, their social history, medications, smoking, drinking, coffee, tea, whatever. We are going into details. And their diet history. And exercise is we always address. We don't want them to be working out too much or not too less. And body weight. Family history is very important. In their mother, father, sisters, brothers, even extended family, we take the history. Any congenital problems, any familial disorders, and what their ethnicity, everything, and then if they have had any previous evaluation. So same type of history is addressed on the male too. Medical, surgical, their developmental history as puberty and sexual function, medications, if he is taking any hormone, herbal supplements, testosterone preparations, previous testosterone injections, all those are addressed. With that comprehensive history, I already know, and then most important is contraceptive history. What contraceptives they have used, if they have been preventing pregnancy at all, or how long they have not prevented pregnancy, how long they have been attempting to achieve conception. So that's
a lot of information. So no wonder it's an hour to an hour and a half long. Is half of the time spent me filling out forms, or do you have people fill out forms of all that data beforehand?
It does help if they fill out their forms, but sometimes they don't. So usually we take the history. So based on all this and duration, how many months or how many years they have been trying to achieve conception, and now all that gives us an idea what to do with that couple. So then we are also addressing the emotional history, psychiatric issue, any psychological issues. Those have all been addressed in the initial visit.
With the fertility tests that people have to embark on, Dr. Vinay Ganala, what are the basic diagnostic tests that they would also do kind of alongside that very comprehensive history that they have to share with you both?
Absolutely. As I do think that the proof is in the details, and often after we get a comprehensive medical history of both partners, we already at that point have a pretty good idea of what we need and where we're going to go from there. But the point of the diagnostic testing for a couple that's having difficulty conceiving is to figure out the why. Why are we not having success, or why are we having difficulty? And it is a mutual, hand-in-hand, equal partnership between the two, in the sense that 30% of couples may only find a female etiology. 30% of couples may find a pure male factor, and then another 25% of couples will kind of have a mild male factor and female factor, and that leaves a sometimes frustrating diagnosis of about 15% where they're purely unexplained, meaning that all of the workup that we have for their fertility testing looks good, but yet that couple hasn't had success. So, the diagnostic testing is really focused on why are they having trouble, and sometimes it can be a little bit overwhelming because it is, unfortunately, a few tests that the woman has to go through, and it takes time because each of those tests are based on a different day of that woman's menstrual cycle. And so sometimes it can be a little bit overwhelming, but I like to tell couples that basically over this next month after we do the initial intake, it's putting the pieces to the puzzle of our fertility, and just getting an answer to why.
Got it. Okay.
And specifically into those tests, from a female standpoint, it's really focused on kind of the quality of our ovulation, our ovarian reserve or our egg count, the evaluation of the anatomy of our uterus, both the anatomy of the uterus as a whole, but specifically the cavity of the uterus, and then the fallopian tubes on whether they're patent, open, or blocked. And then the primary test for an initial evaluation of male fertility would be a complete semen analysis. So it's kind of those 5 tests. Unfortunately, 4 are on the side of a female and 1 are on the side of the male, but equal, both male and female can contribute to difficulty conceiving. So definitely both are important people to be interviewing and testing.
Given that initial consult takes like an hour to an hour and a half, and then you have all the diagnostics, if I'm just getting started in the process and I've already been struggling to conceive for years, time doesn't feel like it's on my side, how fast can I get through that workup?
It really kind of depends on where that woman presents in her menstrual cycle, and then we kind of take off from that point. It could be as early as kind of 2 to 3 weeks. It could be as long as a month, but generally the longest time is a month. Now, all of our tests do not impact a chance of getting pregnant. And in fact, one of the recurring themes is that couples can often get pregnant in their diagnostic month, whether that's because of the flushing effect of a saline ultrasound or an HSG, or whether it's because they finally made a commitment to see somebody, hopefully feel comfortable in our hands, that now they feel like they can, and it just does happen. And so they will often call, one of our happiest calls is, hey, I'm supposed to do this test, but I haven't got my period yet, and they've got a positive beta, and it's not a rare phenomenon by any means. So, it can we definitely instruct them to continue to try on their own during that month that we're doing our diagnostic testing.
That's incredible, and I think infuses a lot of hope with people. And we constantly advocate over and over for people to just get in for that consult, even if they don't even complete 100% of the diagnostics, but they get started. It's empowering, and just learning all that there is to learn. It's such a rapid learning curve for everyone who is embarking on this journey, and I think that's such a great reason to do it. You're in the comfort of these very professional, very well-trained, very educated hands, and sometimes it just makes you relax enough where your body just kind of does the work.
Absolutely.
Whereas telling somebody to relax, definitely we know does not work. There's a lot of data on that. Now, one of the biggest questions, of course, and one of the biggest frustrations is the length of time that it takes for people to take that leap. So, Dr. Sujatha Ganala, when should someone come in to see you?
Okay, so when someone should come to see us depends on the, number one, how long they've been trying. For a woman who is under 30-year-old with no significant past medical issues, if they've been trying for at least 1 year, they gave themselves a good opportunity to achieve the conception. 80% of that couple should be achieving conception after 12 months of no contraceptives. But the other side is, if they have had no periods for 2-3 months in a row, and they're missing cycles, or they have symptoms of severe painful periods, or they have a family history of some underlying disorders, or husband has had some problems, he was born with undescended testes, or he had multiple surgeries, all those are red signals. So I would say at least 1 year of trying for a woman under 30, and 35 and above, they say you should try for 6 months before you seek attention. But if you are a 40 and above, you better start immediately. As soon as you think about that you are wanting to have a baby, please come and see us. because the clock is ticking, biological clock is not going to wait for us. So it is very important to address the problems in a timely and most effectively. Is very important. So I think as soon they think they're trying to have a baby, but they have, the other issue is sometimes a couple consciously made an effort that they're trying to have a baby. But all these years of their marriage, they've been married for 5 years, but 3 years they have not used any contraceptives, but they've been, putting themselves to a risk for pregnancy by not using protection. So, and if no accidents happened and no pregnancies, then that is a red signal. They should immediately see the fertility doctors, or at least address the issue, also with their gynecologist too, some of the basic testing. But I feel like it's a time for them to move on to specialist care.
Yeah, absolutely. Absolutely. So, similar question, Vinay, but a little bit more detail. I think, let's really underscore what those conditions are that would have somebody say, you know what, my OBGYN really isn't prepared to deal with this. I already have an underlying issue. What are some of those underlying issues? Don't leave anything out, whether it's obesity or PCOS or endo. What are some of the underlying issues that we want to advocate that couples, that women get in to see you right away and don't wait for that magic 6 months or 12-month number?
Right. So one is a regular. So by definition, kind of difficulty conceiving or infertility is in a woman that has regular menstrual cycles, because that means that she is inherently ovulating every month, and there's obviously then a chance of pregnancy. But in women that have irregular menstrual cycles or abnormal bleeding, often those women are either ovulating very infrequently or maybe not even at all. And so in women that have irregular menstrual cycles, as you mentioned, there's many kind of different disorders for having irregular cycles. The most common ovulatory disorder is PCOS or polycystic ovarian syndrome. But if a woman carries that diagnosis and now they're in the right position to start a family, well, that patient should not be waiting 6 months or should not be waiting a year, because they're not, they're having trouble releasing an egg or ovulating to begin with. So that would be someone that we should see kind of right away. Another kind of red signal or warning sign that that couple may have difficulty conceiving is signs and symptoms of endometriosis. Now, those are diagnosed clinically, but sometimes women will have proven endometriosis from like a previous surgery. So that would be another patient that kind of should see a physician or a specialist earlier, just because they carry kind of a diagnosis that could increase their risk of having trouble. So there's no reason in waiting for that longer period of time. Other things would be kind of previous surgical history on the side of a female, if they've had multiple surgeries on their ovaries or had an ovary removed for benign reasons before. I think that would be an indication to see somebody earlier. And then on the male side too, if they've had, like my mother said, a history of undescended testicle, or a history of fertility problems and fertility issues, or if they had been on, unfortunately, like testosterone injections previously, then those would be reasons that, they have a higher risk of carrying kind of a male factor diagnosis. And I would say there's no reason to wait at that point. You might as well just come in and get answers. And, this diagnostic workup, sometimes I think there's a hesitancy on couples to do that because they think that it commits them to, God forbid, in vitro treatment or something expensive in terms of treatment. The goal of a diagnostic workup is to figure out the why. And, we have often had patients, it doesn't happen often, but where they're almost contemplating conceiving and just want to get an answer of their fertility. If everything is reassuring, then we don't force them to treatment. We say, you're ready, take that year, take that 6 months, and good luck, and come back to us if you need to.
You are so spot on, Vinay, about this particular topic, that patients don't get in because they have this assumption that they're going to be, quote unquote, sold IVF, and then they convince themselves I can't afford it, rather than accessing fertility specialty healthcare the way that it's meant to be accessed, which is a consultation and a diagnostic conversation. So it's one of my favorite things about your practice that you all are on that page and that you advocate for the same. knowing that there could be multiple different treatment paths someone could take or no treatment path at all. But
Right.
it's the knowledge about oneself so that there's a definitive understanding that is so
Absolutely.
incredibly important. Now, talk to us a little bit about this timing issue, because we certainly know, and Vinay, stick with this for you for a minute,
Okay.
why not to wait too long? And Sujatha brought this up, earlier, saying like, well, if you already know you're 40, don't wait 6 months of trying. That's just nuts. Get in and see, how your ovarian reserve is functioning. So could you take us through that a little bit of just the background of why not wait?
Yeah, so why the recommendations are a year of trying when a woman less than 35, 6 months 35 to 40, and immediate evaluation after 40 is because there is a biological clock, and that biological clock affects both males and females, but unfortunately it's a little bit more sensitive on the side of a female. And really what the age-related decline in the fertility is both in terms of egg count or ovarian reserve, because a woman will lose eggs as she gets older, but she starts to lose eggs a little bit more quickly at the age of 37 and much more significantly after 40. In addition to egg number or ovarian reserve, there's also decreases in egg quality. And that's probably the biggest one. And so, at the age of 30, about 70% of a woman's eggs are genetically normal, meaning good quality, and 30% are abnormal. Not a big change at 35, but at 37, now it's about 50-50. At 40, it's about 60% abnormal, 40% normal, and at 42, it's about 75% abnormal, 25% normal, and at 44, almost about 85 to 95% of a woman's eggs are genetically abnormal or poor quality. And why I would say that is important is because no matter what we can do, we always have treatments we can offer. But one of the few things that we can't control is a woman's egg count and a woman's egg quality. We can only work with what we have. So given those limitations on any fertility treatment, obviously coming in earlier rather than waiting too long, we would just carry a better prognosis, because inherently then we would be working with hopefully more eggs and eggs of a better quality.
I think that's the data is what the data is, right?
Yeah.
And it's incredibly difficult for women in their 40s to hear the data. And we hear so many times women that say to us, but I've been so healthy my whole life. I've taken such great care of myself. I do all the right things. And having to constantly go back and say, the data tells us that doesn't matter.
Right.
I mean, that's hard. That's the emotional part.
Exactly. I mean, here, we see the women who are so focused, career-oriented, or they have so many other obligations, and they're taking care of themselves, they work out, they take care of their diet and all that. They're in such a perfect health, and they come to us at 48, I say, or 45, and say, I'm in good health, I'm still having regular periods. My mom, somebody had baby at 48, like that they do, and they're not accepting the problem. Like Vinay said, it is important. The sooner you consult a specialist is better.
It is. The sooner the better. One final question for you on that topic, Sujatha, is on a couple that, the question is, does a couple need to be actively trying to conceive in order to get pregnant?
Okay. Trying, that doesn't mean, okay, there is again misconception. Before I just said, sometimes they're not even using contraceptive, they're active 2-3 times a week for last 4-5 years, but then they suddenly decide, okay, we want to have a baby in the next 3-4 months, and they try for another 6 months. That's a waste of time, because we already know those 3-4 years they have been putting themselves to the risk for pregnancy.
Right.
For example, the sperm lives in a human body for 7 days, 5 to 7 days. But mostly it's more fertile maybe for 3 to 5 days. But egg is living only for 12 hours. If a couple are active, say in a woman who is having regular menstrual cycles, from cycle day 10 until maybe 20, if they are active like every 2 days, that's all it takes. We don't need fertility monitors, we don't need ovulation predictors, you don't need to have, they have to have it that minute, that day. No, it's not necessary. And we often see that a lot of emotional pressure on the husbands too when they have to perform on demand. So it is very important to keep it, to be, to be more realistic about it, and then commit yourself to the testing, whatever needs to be done.
I love that sentiment, this on-demand sex, and we're not talking about the porn industry. We're literally talking about how couples approach it. And,
Right.
and it removes all the romance, it removes all the sexiness from it, right? And it becomes
Right.
this like, I gotta get my timing perfect, and the charting and the temperature tracking,
Exactly.
and the ovulation kit and everything else. And if it's that hard, they need to come in and see you, right? If it's
Right,
requiring
exactly.
that much work and study to understand what's going on with the body and why it's not working, they've got to get in to see you for a consult. That's the bottom line.
Bottom line, like, yes.
Yeah.
And I'm sure that maybe Vinay will address with you the causes of infertility, and you can see what are the, so various different problems can contribute to the infertility issue.
What's kind of cool is that, with my mom kind of starting of, not to go too far into the history, but with my mom kind of starting when there was nothing, of like she said, she was a pioneer and matriarch and had to kind of fly to different places to learn these techniques. Now the things have been so advanced that, we are really gifted and blessed right now training with all the tools that we have, which can sometimes be taken advantage of and miss. And I always now get kind of reminded on how hard it was for my mom starting and where she started. And, I think that is just something that kind of continuously reminds me of like how powerful and strong of a woman my mom is and how impressed I am by her, And so it's kind of like two different times when we've started our career, but, where I've started now there's constant, I guess, reaffirmations of like how much she had to go through that I just never knew about,
Well, the other thing I think about when it comes to your mom and all those years ago is the amount of failures, right? I mean, it took pioneers like your mom so many years to improve the techniques, to perfect the techniques. Even when I did my fertility preservation treatment, and oocyte vitrification didn't even exist yet.
Right.
So we were working with experimental labels and 2 to 3% success rates, right? And so the fortitude that it took even to just like stay in practice and kind of deal with that emotional side for yourself of you've got these same number of desperate people sitting in front of you who want this dream of family.
Exactly.
It must have been incredibly hard.
We would do everything, exhaust every treatment possible, medical, surgical, before we can even suggest IVF. But what is unique about this practice is you are blending the old established methods to the new ones, and like maybe Vinay can talk about his background training, that mending the old versus new and being able to offer to the couple the new, all along I've been on the cutting edge, learning as we go, during surgical treatments, laser surgery, things like that. We learned as we went as I was practicing. But the new treatments, Vinay was exposed and got trained with hands-on training with experts, with pioneers in the country, and he brought that knowledge to this practice, which is, I think our patients are going to benefit from that.
Absolutely.
I've been fortunate to have wonderful mentors throughout my medical career, but my biggest mentor was definitely the mentor that I didn't even really know before I got into this field, which was my mother, obviously. But I think a physician is only as good as the mentors that train them. And like I said, going out to being privileged enough to go out to New York and train for both general OB/GYN residency and, more importantly, kind of REI fellowship at Cornell, which is one of the largest academic centers in the nation and in the world, in terms of volume and in terms of the amount of experience that they have under one roof. Obviously, is beyond blessed to have been trained by them and learn and always kind of put the cutting edge and what different things that we can do to treat very difficult patients in terms of their prognosis, but still maintain excellent pregnancy rates. Just allows you to see everything. And then therefore, when you get out, you've seen almost everything at least once. And no doubt it's always great to have my mother with all of her experience to be a great sounding board off ideas and how we want to do. But, you know, one of the great things was that Cornell, no matter how much they were pushing the envelope, the patient always came first in terms of what they wanted and in terms of individualized treatment. And that just happened to be something that my mom had already been doing for, you know, since 1980. So it was a very, very easy way to mesh both of our minds and thoughts in how we wanted to practice for our patients.
That's great. I promise you this, we will do an entire episode on reproductive surgeries with you and your team and how you approach that aspect of the practice as well. So I love this. This is your Fertility Edge episode on the infertility workup itself. It can feel really overwhelming. We understand that. That's why we have navigators who can hold your hand along the way and kind of break down what those steps look like. But if you know that parenthood is in your future and you see a vision of yourself as a mother or as a father, we are here to help you get in for that consult and get to the bottom of the why, like Dr. Vinay Ganala said. So I want to thank my guests, Dr. Vinay Ganala, Dr. Sujatha Ganala. Thank you both so much. We're so lucky to get to work with you and to know that we're sending our patients to such a trusted, family-oriented environment.